All right, so we'll be assessing the abdomen, neural and musculoskeletal system. So we'll start with the abdomen first. Here we have an Asian male, fair skin, appropriate for his ethnicity, well kempt, well dressed, alert oriented. Okay, so I'm gonna have you lay back, sir. We're going to assess the abdomen first. So we're gonna lift your shirt up. We're gonna inspect first. So upon inspection, there's no discoloration, no scars, no rashes, or no obvious skin issues. His skin color is the same with the rest of his body. I don't see any distension either. If there were, then we'd be worried for issues like ascites or some kind of hernia if the patient has a history of that. Okay, and then I would look at for any peristalsis at the foot of his at the foot, and that's negative, which is a normal finding for this patient. Okay, so after inspection, we're going to be auscultating for bowel sounds. We're going to be starting off at the right lower quadrant. All right, and then right here. Oh, all right, and what I should be assessing for are normal active bowel sounds, which he does have. Okay, so if we were to listen to hypoactive bowel sounds rather, we'd be concerned for some kind of ileus or bowel obstruction. Any hyperactive bowel sounds, we'd be thinking maybe this patient has like bouts of diarrhea. Okay, so that's auscultation of the bowel sounds. Now we're going to auscultate the vascular sounds, for vascular sounds rather. Okay, so we're going to start at the aorta. All right, then we're going to listen out to the renal arteries. So far, no bruits, which is a normal finding. Now listen to the iliac, which is lateral of the umbilicus. Otherwise, if we did hear any bruits, we'd be concerned for some kind of vascular obstruction femoral. No bruits. Okay, so now after the bruits, after the vascular sounds, we're going to percuss all the quadrants. So with the abdomen, we should be percussing tympanic percussion, except for when we're over organs, okay? Tympanic. All right, now we're reaching dull, which is the liver, and if we were to percuss even higher, we'd reach renaissance, and then which is the lungs, so we can estimate the size of the liver. We're gonna go on to the part of patient, tympanic. You may or may not hear or feel dullness with the spleen because it is underneath the rib cage, but around the 6th to 10th rib, then you can feel the spleen. I'm gonna go down, tympanic, all right? And if the patient's bladder was full, then you would also percuss dullness here too, all right? And then around the umbilicus, it should be like hypertympanic, okay? So now that we've percussed quadrants, like I said, we've already percussed the liver, we've percussed the spleen. Now we're going to go on to light palpation. So if a patient was having pain anywhere, we would do that part last, okay? So just let me know. Any pain?
Nope.
Any pain?
Nope.
Or any pain here?
Nope.
Pain here?
Nope.
All right, so patient has no pain, which is good. Now we're going to move on to deep palpation, where we're going to be really feeling for the organs. So deep palpation, let me know if you're having any pain here.
Nope.
All right, so his abdomen is soft, which is a good finding. All right, there's no muscle rigidity, no mass, no tenderness. All right, so we're going to palpate the palpation. Now we're going to palpate for the abdomen aorta. So we're going to start the umbilicus and go up some. So it bifurcates here. So what we're going to do is just kind of like feel for it. Go in the lateral side. It should be less than 3 centimeters. Okay. Good. Okay, good. All right, so that's palpating for your. Before you do that, make sure you assess for pulsation, because if there is some kind of pulsation, then you risk rupture. All right, so now we're going to just palpate the patient's liver border. All right, so what I'm going to ask you, sir, is to just breathe in real quick. All right, good. Any tenderness?
Nope.
Okay, good. All right, now you can breathe out normally. Now we're going to palpate for the spleen. We're going to start the umbilicus, then move our way diagonal. All right, any tenderness?
No.
All right, if there is any tenderness, then of course you'd be concerned for some kind of like inflammation going on there, okay? Now we're gonna palpate the kidneys. Usually it would be on the right side of the patient, but for the purpose of this video, we'll just stay on the left. You'll be able to palpate the right kidney a little bit more than the left. So I would just lift his blank area up and just palpate down, okay? And I can see that it's smooth and firm. Any pain?
No.
All right, same thing for the left. Let's see if we can go a little higher. Left flank up, palpate. Any tenderness?
Nope.
All right, good, which is a normal finding. All right, now we're going to be assessing his upper extremities. So what we're going to do first is inspect his clavicles, AC joint. We're gonna process any tenderness.
No.
Shoulders. We're gonna just palpate for his biceps and triceps. All right. So right now, you see he's symmetrical in contour, which means there's no kind of like dislocation to be concerned about. No tenderness, no redness, no bruising that I can see. So there's no concern for any infection, inflammation, and such like that. Okay. If there was some kind of like asymmetry, then or tenderness, maybe we can be concerned for some kind of ligament or shoulder dislocation. All right, and we can palpate the spine of the scapula. Any pain here?
Nope.
All right, I'm gonna have you turn around. As you can see, there's no wing of the scapula, which is a normal finding. All right, we're gonna go back. Now that we palpated and inspect and palpated the clavicle, scapula, and the shoulders, we're gonna move on to, in the joints, we're gonna move on to range of motion. So what I'm gonna have you do, sir, is just like put your arms around your neck like this. All right, and then what we're going to do, we can do the opposite way. We're going to have your arms go back and twist like this. All right, so that assesses for range of motion. So what we've done right here is externally rotated and internally rotated. Internal rotation, okay? So he was able to do it nice and smooth and without any difficulties. If there was some kind of sharp pain, then we'd be concerned for some kind of rotator cuff impingement. Okay, so now we're going to test the bicep strength. Okay, I'm going to do what I'm going to have you do. I'm going to have you pull your forearms to your body while I pull against you. All right, good. All right, so that tests bicep. Now I'm going to have you put your hands towards me. You're going to push me. All right, and that assesses for tricep strength. So we're gonna, they're both 5 bilaterally. All right, so now we're going to flex and extend his elbow. What I'm gonna have you do, I'm gonna have you just flex your elbows right here, and then we're gonna have you extend. And again, he was able to do that with no difficulty. He was able to do it smoothly, which is a normal finding. Okay, so now we're going to test the range of motion for the neck. I'm gonna have you do is just put your chin down to your chest. We're gonna have you look at the sky, extend your neck all the way down. Good. We're gonna have you put your neck, move your neck from the side to the left, side to the right, and then range of motion is intact. Okay, so what I'm gonna have you do, I'm gonna have you move your head to your left side while I'm pushing against you. Good. And then opposite side. Good. And I'm gonna have you do is just shrug your shoulders while I push down. Okay. All right. That also assesses for cranial nerve 11, okay, which is intact, which assesses for the spinal accessory muscles. Okay, since he was able to do that, normal finding. Okay, so now we're going to assess for the reflexes. We're going to do the bicep first, doing the right side. Just relax your arms, sir. All right, well, if you're able to see that there was some kind of contraction and he was able to contract his arm, or go on the other side. Relax, relax. All right, if you can see that he did contract his, there's some kind of contraction in his hand. Okay, so now we're going to move on to the brachioradial reflex. We're going to just go there. What we should be seeing is some flexion and supination of his hand. Oh, okay, if you saw that, that's intact. On the other side. All right, you saw a little bit. We're gonna move on to the tricep reflexes. So we're going to just get your arm. Relax, relax, relax. Let me sit up straight. We can sit up straight, sorry. All right, a little contraction over there. We're gonna go to his left side. Relax, relax, relax. All right, little contraction there, which is great. Okay, so we did a reflex. Now we're just going to palpate for his radial and brachial pulses. We're going to do it bilaterally at the same time. It should be strong +2, which he does have. And then radial pulses is where the thumb is. His watches is kind of in the way, but we'll do the best that we can. +2 strong pulses, which is a normal finding. Okay, now we're just going to inspect the hand, wrist, fingers, and hands. As you as we inspect them, there's no obvious masses, redness, or bruising, discoloration on his hands. Now we're going to be palpating them. All right, no swelling, no nodules, edema masses. We're also going to be just assessing the snuff box over here. Any tenderness, any pain? Okay, good. All right. Okay, I can also see that his hands are warm. We also already palpated for the radial pulses. We can also palpate for our own NUR too, since while we're at it, which is where the pinky is at, which is +2 bilateral, which is the normal finding. Okay, now we're going to just test for range of motion and strength for the hand. What I have you do is just flexion. Put your hand like that. All right, which is flexion. We're gonna extend your hand like that. Beautiful. Any pain?
No.
All right. If he did have some kind of limited range of motion, then we'd be concerned for inflammation or some kind of dislocation. Okay. So what we're gonna do again? Put your hands like this. We're gonna have you adduct, yeah, and then abduct. All right. Any pain?
No.
All right. No limitations in his range of motion or strength. Okay. All right, now we're going to be assessing for the lower extremities. We're going to start with the hip and pelvis, where I'm going to have you just sit up for this inspection and palpation. Normally, he would be laying flat, but for the purpose of video, we'll just inspect him here. So, I'm going to have you turn around. No obvious like redness, no obvious redness, masses, swelling going on. So we're going to have you turn around again. What we're going to be starting off is to just inspect or palpate the iliac crest. We're going to go anteriorly. Let me know if you feel any like pain.
No.
All right, we're going to go down to the greater contractor of the femur. Any pain?
No.
All right, we're going to go back posteriorly. Any pain?
No.
All right, we're going to go down to ischial-tuberosity. Any pain?
No.
All right, if there's any pain or tenderness or crepitus, we would be concerned for inflammation or some kind of nerve or compression fracture. All right. When you see a patient, of course, assess their gait. We'll just say for the purpose of the video that his gait was steady, which is a normal finding. Okay, so actually I'm gonna have you stand up again. We're going to be testing his range of motion. We're gonna be going down a bit so we can take a look of the range of motion. What I'm gonna have you do, I'm gonna have you cross your right leg over to your left. All right, good. We're going to do the other way. You get on cross, and that says it's for adduction. All right, then you can go for both legs. What I'm going to have you do is have your legs go off to the side like this.
Oh.
Yeah. All right, good. That's abduction. We're going to go for the other side too, so we can see that his range of motion is intact. Okay, so he's able to do it smooth without any difficulty. If he did have an issue with it, then we'd be concerned with hip fracture and inflammation. Okay, all right, we're gonna have you sit down. Now we're going to be inspecting and palpating the knees. Okay, upon inspection, there's no obvious swelling, redness, which is a good sign. So we're going to be just palpating, starting with the femur, patella, tibia. Any pain?
No.
All right, we're gonna just go one by one. Tibial plate. Tibia should be flat. I don't feel any crepitus. Same thing for this side. Any pain?
No.
All right, good. All right, so no pain or swelling. There is some kind of pain or swelling, then we be concerned for some kind of bursa rupture, okay? And for my assessment, no masses either. All right, so what we're gonna do is just assess for range of motion. What I'm gonna have you do is extend your right knee forward. All right, your left knee forward, and as best you can, you're going to flex it backwards. Right first. Good. Left. All right, any pain?
No.
All right, good, which is a normal finding. Okay, so what I'm going to do is now just test your strength. I'm going to just be applying force. I'm going to just try to extend your legs, okay? While I put it back. Beautiful. And then opposite way. All right, so the strength is a 5 for both for both assessments. Okay, so now while we're at it, if we can, we will inspect and palpate the ankles and feet. And as you can see, we'll just palpate the ankles. We're going to just take a look at the talus, medial and lateral malleosis. Right, any tenderness?
No.
Right, the heel.
No, thanks.
Okay, and then ankle joints and Achilles tendon. Any tenderness?
No.
All right, this patient is a runner here, so he does have some kind of calluses on this side of his toe, okay, which is normal finding someone's a runner. Okay, no mass tenderness noted, which is a normal sign. Okay, and while we're at it, we'll just palpate for the pulses, dorsal pedis. All right, good. +2 strong, and then the posterior tibialis. Good. +2. Now we're going to assess for range of motion of the ankle. So what we're going to do is just going to help him up because he's a little tall. What we're going to do is have you point your toes down, point up, so that assesses for plantar and dorsiflexion respectively. We're going to do the same thing for the left. We're going to point your feet down, point up. All right, no limited range of motion, which is a good sign. Now we're going to just assess for strength. What we're going to do is just point your feet up. Good. Feet down. Good. Left side. Up. Down. All right, so we'll rate his strength of 5. Okay, so now what we're going to do, we're going to go out to the knee and assess for his patellar reflex. Again, I'm just going to lift them high because he's a little on the taller side. All right, we're going to do, all right, a little contraction there, which is a positive sign, normal finding. All right, contraction in the left patella. Okay, so now what we're going to do, we're going to assess for the Achilles and plantar flexion, reflex rather. And just lift his up, and just strike the Achilles. All right, a little bit of contraction here, again here. All right, little contraction there too. Now we're going to assess for the plantar reflex. What we're going to do, I'm just going to touch alongside his sole. What we should be seeing is actually downward curling of the toes instead of upward fanning, okay, which is not a normal finding in adults, but it is in kids. All right, no extension. All right, no extension either, okay? All right, which is normal. Now we're going to move on to spine. So what we're going to do, have you stand up, follow that up too, stand up. We're going to have you just turn your back towards the camera. And as you can see, we're going to be assessing his posture. What we can see, his back is straight, it's symmetrical, and we're going to just palpate for the spinous process, okay? There's a nice curvature. Any pain?
Nope.
All right, if there's any pain along the spinous process, we'd be concerned for like a tumor and such like that, okay? And we can see that his arms hang symmetrically. If his shoulder were kind of like tilted, then we'd be concerned for conditions as lordosis, kyphosis, scoliosis. And speaking of that, we'd have you bend down, and you can see that his back is straight, okay? I'm gonna have you just turn around. At this point, we're going to be assessing for range of motion. We're gonna flex down, touch your toes. All right, he's able to touch his toes. We're gonna do it now. Stand up, turn to the side, extend all the way, stand as back as you can. All right, any pain?
Nope.
All right, there's no limited range of motion on his case. If there was, then we'd be concerned for some kind of this issue. What we're gonna do now, you're gonna just lean to the left, lean to the right. All right, good. So that is the range of motion for the spine. We're gonna have you sit back down again. We're gonna do a couple more tests. What we're gonna do now is to do the rapid alternating movement. We're gonna be testing for the cerebellar functions now, okay? So what we're gonna do, have your hand up, and then flat down. And you're going to keep doing that as fast as you can, okay? So as you can see, the patient is doing it quickly and rhythmically. And now we're going to just do the heel to shin to test for leg dystocia, or also test for coordination. I'm going to go down again. What we're going to do is just have you touch your right heel to your left shin. All right, and then your left heel to your right shin. Okay, so he was able to do that. He was able to run his legs down in a straight line, which is a normal finding. All right, now we're going to be assessing for the exteroceptive sensation. We're going to be starting with superficial pain first. Just to let you know, it's going to be sharp and it's going to be dull, okay?
Okay.
All right, please close your eyes. Let me know if it's sharp or dull.
Sharp. Dull. Dull. Sharp.
All right, so that's intact. Now we're going to be assessing for temperature. Close your eyes, please. Let me know if this is hot or cold.
Cold.
All right, good. Let me know if this is hot or cold.
Hot.
All right, good. All right, now we're going to move on to proprioception. We're going to test for the motion and position of his hands. So I'm going to have you close your eyes. I'm going to move your finger. You let me know if the position is up or down, okay?
Up. Down.
All right, so if there's any deficits in the hand, then you'll move on to the lower extremities, okay? Now we're going to test for vibratory sensation. What I'm going to do, I'm going to get this 24. I'm going to go in the joint. I'm going to vibrate it. You let me know when you feel it, and then you let me know when you don't, okay?
Okay.
All right, close your eyes, please. You feel it?
Yes.
And let me know when you stop, okay?
Okay. Stop.
All right, do you want more on the other hand? Let me know if you feel it, please.
I feel it. Stop.
All right, good. So that is intact, okay? So now we're going to move on to the cortical sensation, where we're going to be testing the serognosis, which I'm going to place items in your hand, and you let me know what they are, okay? All right,
Okay.
close your eyes.
A coin.
All right, close your eyes. Keep your eyes closed. And what is this?
Key.
Okay, good. So that's intact. Now we're going to test for graphesthesia. I'm going to write a number or a letter in your hand. You let me know what it is, okay?
Okay. 3.
All right, good.
13.
Yes, good. All right, good. So that's intact. So now we're going to do a 2-point discrimination, where I'm going to get these 2 points. What I'm going to do, I'm going to poke. You let me know if you feel into different points, and I'm going to go closer and closer, closer. You let me know when you can't diminish the feeling anymore, okay?
Okay.
Close your eyes. Different?
Different. 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 1.
Okay, good. So 2-point discrimination is intact. Now we're going to assess for extinction. What I'm going to do is just put hands in both of your wrists, and then you let me know if you feel it on 1 or 2 hands, and then you let me know if you feel it on 1, okay?
Okay.
Okay, close your eyes. How many wrists am I grabbing?
2.
All right, how about now?
1.
Okay, good. So extinction sensation is intact, so his cortical sensation overall is also intact, okay? All right, now we're going to be, I'm going to have you stand up. We're going to be doing a little walking, standing, on tiptoes and such like that, okay? So I'm assessing how he gets up from sitting to standing, which is normally he was able to do it nice and smoothly. I'm going to have you just go at the edge of the couch. What I'm going to do is just have you walk on your tippy toes towards the camera. All right, now walk backwards. I'm going to have you walk on your heels. All right, good. Now walk backwards. So he's been walking forward and backwards. I'm going to have you side step to the left, side step to the right. All right, good. So he's able to do it nice and smooth. If he was having any issues, then we'd be concerned for some kind of cerebellar disease or some kind of muscle weakness, okay? Now what we're going to do is, his eyes are closed, okay? So what we're going to do is just have you put your feet closer together. We're going to test for Romberg sign, okay? Observe for any swing. We're going to have you open. His eyes are open, all right? No swaying. I'm going to have you close your eyes. All right, no swaying either, okay, which is negative. If his Romberg sign was positive, then we'd be concerned for conditions such as like MS, okay? So last thing we're going to do is just assess for pronated drift. Want to have you do stand with arms extended with your palms up. I'll go a little higher. With your palms up. And as you can see, there's no drift, okay, which is a normal finding. If there was some kind of drift, then we'd be concerned for hemiparesis, which would indicate a stroke.